on to Dr. Rishi Swarup. I'm sure he's going to come up with something brilliant as far as cornea and dry eye is concerned. Look forward to your case discussions, Rishi.
Thank you, ma'am. The mandate given to me by Dr. Partha was to share a couple of cases of dry eye in corneal disease. So that's exactly what I'm going to do. It's not much of a didactic talk, and then we can have a discussion later as has been discussed. So this is my first case. It was a 10-year-old male boy who presented with this known case of an allergic conjunctivitis. He presented with itching, watering, discharge, and redness more in the right eye than the left eye, with recurrent episodes of inflammation since 2 years. He also gave a history of chicken pox followed by mouth ulcers 2 years ago when all of this started, and was using lubricant drops when he came to me in the clinic. His vision was 6/18 in the right eye, and left eye was normal vision. And objective refraction could not be done as he was very symptomatic. So on examination, he had keratinization of the lid margin with papillae, lots of papillae in the upper tarsal conjunctiva. Cornea I'll just show you, and rest of the anterior segment was within normal limits. So this is how his right eye was looking. He had it's like a shield ulcer-like appearance with a plaque on the cornea with lots of staining of the cornea, as you can see here. And you can see when we inverted the lids, you could see that the tarsal conjunctiva was very inflamed with lots of papillae, thickened conjunctiva. And you can see this keratinization at the lid margin, both in the upper and the lower tarsal conjunctiva and the lid margin. This was his left eye. Even the left eye showed a lot of papillary reaction, and there was a little bit of keratinization in the center of the lids, in both, more in the upper lid and slightly in the lower lid. The tear film breakup time was 8 and 7 in right and left eye, and Schirmer's was normal. So I made a diagnosis of shield ulcer in the right eye and a combination of a Stevens-Johnson syndrome and a chronic vernal keratoconjunctivitis in this particular case. So I felt that both the conditions pre-existed. A patient was, in addition to lubricant drops, was put on topical cyclosporin and corticosteroids in the right eye. And a patient was planned for plaque debridement with amniotic membrane graft and mucous membrane graft in the right eye. So some people could argue that the mucous membrane graft was a bit of an overkill, but I wasn't sure whether this was contributing to his corneal condition also. And since we were anyway putting this child through GA, I decided that we can go ahead and do a little bit of mucous membrane graft as well. So we did do that, and we kind of excised the keratinized lid margin and replaced it with buccal mucous membrane, with the labial mucous membrane, and also put amniotic membrane graft on the cornea. You can see after some time, the cornea cleared up very nicely, leaving behind a mild scar in the area where the shield ulcer was existing, and the lid margin became very healthy, and the tarsal conjunctiva quietened down quite nicely. And this is how the patient was in the subsequent months. You can see that the lower lid was not touched. We did leave behind that little bit of keratinization in the lower lid. I didn't want to do an extensive surgery and prolong the surgical time. That's why we left the lower lid as it is, because it was not in the center, it was to the side, and I didn't feel it was contributing much to the corneal condition. And over time, the patient actually did quite well. You can see the lid margin almost became like a normal lid, and the cornea became wet and healthy, and lost only except for the scar, there was no staining of the cornea. There was a lot of residual astigmatism from the scar, of course, and the patient did improve to 6/12 with subjective correction, but otherwise the surface was very healthy, and it became very quiet after a long time. And you can see even on staining, there was nothing much. So these are just subsequent pictures. So from that condition, we kind of came to this from the left to the right, and the patient did well. So this was the reason I'm presenting this here is because it was a VKC, not VCK, complicated by SGS. Should the MMG in the lower lid also have been done? Was the MMG at all necessary? These are questions which are up for debate. And should we be addressing the astigmatism, or should I just leave this eye as it is? Should I present my other case or shall we discuss this first?
We
I
can
think-
go to your next case also,
Yeah,
Rishi.
the second case is very quick. I'll just quickly present it. Sorry. Yeah, so this was another patient of SGS actually. She was a 40-year-old school teacher. Came to me in 2011. She was diagnosed already as a case of SGS by a local ophthalmologist, had already undergone mucous membrane graft for the lid margin in the left eye. And because she was moving to Hyderabad, the primary surgeon had referred to me. She had pretty good vision when she came to me, but came with complaints of pricking and pain in the left eye since a few days. And when I saw her, there was a mucous membrane graft, not OS in the left eye, in the upper lid. She had clear cornea in the right eye with few SPKs, but the left eye, she showed this kind of a focal infiltrate with a lot of SPKs around it. Schirmer's was 4 millimeters in the right eye and 2 millimeters in the left eye. So I thought this was a secondary infection because of epithelial breakdown, treated her with preservative-free lubricants and antibiotics. And over time, the infiltrate resolved, leaving behind a scar with some thinning. After that, the patient was maintained on preservative-free lubricants. Eventually, the cornea quietened down and the eye also quietened down, but the patient had lots of symblifera and fornical changes, etc. And of course, the lid margin keratinization was there, as you can see in the pictures in the left eye, and then the right eye had an MMG in place. Now, in between, the patient was lost to follow up with me and went back to the primary surgeon, who performed a deep lamellar keratoplasty for the central scar that she had developed in the left eye. Also, there was an element of ectasia which was there. So the patient, after undergoing the surgery, came back to me, and she came to me with complaints of pain, watering, and pricking in the left eye. The deep lamellar keratoplasty was done in the left eye, which is always the worst side. And she had a vision of 6/18 in the left eye. And when I looked at her, this is how the left eye was looking. The MMG was well in place, but the graft, as you can see, was clear centrally, but on one side there was a large epithelial defect and there was a haze in the graft. And eventually this, I don't have pictures after this, but the patient actually had a very bad course. The graft went on to melt and there was an interface exudation and separation of the desmus membrane from the lamellar graft. So, and a lot of surface inflammation and the blood vessels were coming into the interface. So I decided that this was not going to do well. So we decided to change the graft to a larger limbus to limbus graft, along with an amniotic membrane graft and tarsorrhaphy. We had done a lot of other procedures in between, multiple BCL applications, MMG, AMGs, tarsorrhaphies, nothing worked. So I had to do this. For a few days, he did well, but again, the cornea started taking up a lot of stain, as you can see in these pictures. And then we used to treat it, used to get better, but again, would come back with a lot of staining of the surface and a very dry surface, as you can see in the slit pictures. And eventually, again, the epithelium started to break down and the patient started developing persistent epithelial defects who had underwent AMG, tarsorrhaphy multiple number of times. And sometime in between, he even had a cataract surgery while he was stable. After that, he developed an infection in the graft along with the persistent epithelial defect, as you can see. Again, medical therapy, tarsorrhaphy, this saga was just continuing. Eventually stabilized, then again came back with a PED, put a bandage contact lens. So something or the other was constantly going on. At this point, I decided that I had had enough and I had exhausted all my options. So I decided that we could try PROS, scleral contact lenses. So I referred him to LV Prasad, and after which the patient hasn't come back to me. So the reason I present this case here is because grafts in Stephen Johnson cases are very, very challenging, and one should really think 100 times before we really think of doing any keratoplasty in a patient who has bad tears and bad ocular surface, because they are prone to recurrent epithelial breakdowns. You might think that the eye is doing well for a while, but they will eventually come back with some sort of an epithelial breakdown or PED or an infiltrate. And these are very difficult to treat. So doing a graft will make it many-fold worse. And we should be very, very, and graft should be really the last resort in these patients. Thank you. Just wanted to share these two cases and we can have a discussion on these topics.
So for the discussion, Dr. Quresh Musketi, sir, and Namrata.
Yeah, see, starting with the second case, I mean, Rishi was soft pedaling his words there, saying graphs are challenging in Stevens-Johnson syndrome. According to me, the correct word to use is a two-letter word, which is no. That means no graph in a Stevens-Johnson syndrome. I mean, all of us have burnt our hands at some point or the other. Why would we still do a graft in a Stevens-Johnson when, as Rishi correctly pointed out, the epithelium is prone to breakdown? There is sympleps happening. I mean, I was trying to count the number of times Rishi used the word tarsorrhaphy. I think at least 6 or 7 times that he mentioned it, maybe 6 or 7 times. That imagine lids being cut and sutured, cut and sutured. I mean, and for what purpose? If at all you want to give vision to these patients, you can think in terms of a keratoprosthesis of some sort as a last resort if it's the only eye. But otherwise, in a Stevens-Johnson to play with dalks, whether it's a large diameter dalk or a small, the epithelium still needs to grow over, which just doesn't happen. Yeah. In the first Rishi, the first one where you mentioned the Stevens-Johnson, where with the VKC, it was an interesting case diagnosed correctly by you, would have been missed by many people and just gone on to treat as VKC because of the history of chickenpox, which was there earlier. So you did do a good job with the MMG, and I would agree that there was no real need to do a lower lid MMG. Even the upper lid, you did, and it did work. But perhaps even without the MMG, just knowing that there is a Stevens-Johnson and treating it as a Stevens-Johnson with VKC may have still worked, because the lid keratinization in the upper lid didn't look all that bad to me.
Yeah, the
Not
only
like in a
reason I did it
classical,
was because we were taking the child under GA anyway for the
correct
ulcer. So I thought I might as well add this. And something worked.
It did help. It did help. Yeah. So it worked out. But suppose you are not taking up the child, maybe even without MMG, this result would have come, provided you were vigorous with your SJS therapy. So congrats to you on managing both the difficult cases. And I sympathize with you, because the first surgeon did the DALC. You just have to manage after that.
So, Dr. Basak, sir, any comments from you? Dr. Basak, sir? Okay. So, if he's not there, let's go over to Pragya. Pragya?
Can I add a couple of comments? Yeah.
Please.
So, Dr. Rishi, they were really interesting cases. So what I have observed is even if there's limbal stem cell reserve and there is an epithelial defect, some of these patients with SJs actually epithelize, even with just medical therapy or with AMG. But when we transect the nerves and actually go in and do PK, or even if it's a DALC, it doesn't have to be lamellar or full thickness. I've seen that they do exceptionally bad. I've had a couple of patients where sometimes they're perforated. You just don't have any other option but to do a penetrating keratoplasty. You're surprised and actually very happy that the surface has epithelized. So there is some limbal reserve. So the cells are coming in and it is getting epithelized, but I don't think it lasts even for like probably 1 or 2 weeks, and it starts to break down and enters into a vicious cycle. So I think more than limbal stem cell deficiency in these eyes, the dryness is the reason why their grafts fail. And whenever there is a low Schirmer's, I think we try to do something to salvage, but I don't think we would really gain much. Even keratoprosthesis, if we are lucky and there's some conjunctiva coming and epithelizing or dermalizing, that's the only way these things work. But otherwise, we've anyways, I think,
I've
gone
seen
down.
many of them who even have a lot of tears. Somehow they just keep coming with epithelial breakdowns. It's more than just low Schirmer's. I think it's more to do with.
Yes, in some patients, I think it's the inflammation. Periodically, it exacerbates, and you don't know why. Maybe it's the inflammatory mediators, and because they're limbus is not all that healthy, but definitely the ones with dryness, I think they just go downhill. You run out of options. The only other way to do it is do a type 2 K-Pro, go ahead, do an ocular surface MMG, let the surface heal, then go in and put a K-Pro beneath the MMG or beneath the panis. That's the only thing. But in this case, we wouldn't have that much time to do anything. The cornea would melt and perforate.
Right. Pragya, your cases now.